Welcome to the inaugural series of the Iowa ACC podcast. My name is Amit Bahia. I'm a cardiologist at the Genesis Medical Center in Davenport in Eastern Iowa. And I have the distinct pleasure of inviting Dr. Kotev. Dr. Kotev is the governor of the Iowa chapter of the ACC and a medical director of cardiology at the Mercy Hospital in Iowa City. Dr. Kotev, welcome.
Thank you, Dr. Bahia. It's a pleasure on this chilly Saturday morning to talk to you.
Thank you. Thank you for giving us the time. I want to start by asking you about the subject of rural cardiac care. Iowa is a mostly rural state, and most of our patients live in rural communities, far separated from urban centers. What are the challenges that our patients experience in receiving cardiac care? And what are the difficulties that, as providers, we encounter in taking care of our patients? I would like to ask your opinions on that.
Yes, sure. You're right. Iowa, and as many other Midwest states, has very large areas of loosely populated areas. And there are great distances that the patients need to travel to get to hospitals or to specialists. And part of that is the trouble for us as physicians and as systems, healthcare systems, to actually recruit physicians, nurses, and to retain them in the rural areas.
There's been, sorry, go ahead.
Yep. Part of the problem with the physician recruitment and retention is actually the cost of running practices. For the last 20 years, the cost of running a practice has increased with 47%, and at the same time, the Medicare reimbursement has actually dropped by 26%, accounting for inflation. On top of that, just for the next year, 2024, there is a proposed 3.36% reduction in the Medicare physician fees. So all this makes it almost unsustainable to run a practice, especially in rural areas.
So the challenges are primarily driven by a reduced workforce. There's also been financial difficulties that a lot of access care hospitals are running into. We read about hospitals that are shutting down in smaller communities. How does that affect the practice of cardiology for providers like you and I?
It does affect a lot. It's everything, all the prices of running a practice, of retaining nurses, of delivering care to outreach locations is increasing. And then just trying to run it in a place where there are not many patients that can come to that place, like a remote one, it's very difficult. Makes it really hard. And for example, our own institution has pulled out from most of the outreach places now just to concentrate in the main hospital, and many other organizations are doing the same across Iowa, which is really not a very optimistic trend.
So this seems to be a pervasive problem affecting perhaps not just the Midwest, but southern states and out west, where the access to care is a challenge. How has the ACC been leveraging its position to try and improve the access to cardiac care for our patients?
True. The ACC is a very large organization. That's our home for all of us cardiologists, regardless of the subspecialization. And they've been lobbying, and we're really working on the advocacy front a lot over the last few years. Right now, there is a House and Senate bill. It's called the Strengthening Medicare for Patient and Providers Act, which the ACC fully supports. And we have the support of at least few of the physicians, which are senators and representatives. So that's really an optimistic step. And this bill actually is expected to adjust the reimbursement from Medicare and adjust it to inflation. So that's more of a long-term solution. So we avoid the constant lobbying every year at the end of the year, where we need to decrease the expected cuts, which are happening every year.
Very nice. through the pandemic, all of us adapted to meet the challenges of caring for patients and protecting ourselves and our own health. A lot of us do outreach in our practice where I work, and we also try and see patients remotely using web-based tools. How do you think that as individuals we can provide greater access to care and help our patients with all the challenges that we have to face?
Correct. Yes. Especially since the pandemic, there have been actually more physicians retiring than actually entering the workforce since the COVID. And part of it is aging of the physician workforce, and part of it is the burnout. And maybe the silver lining of the pandemic is that we kind of get used to, and some of us actually very proficient with telehealth. So that's probably an area which is really, it would be really helpful in rural areas, especially in Iowa, where almost any person now has a smartphone and can access their doctors just from a simple app that you don't even need to pay for it, like a Zoom, and there are many other apps. So I see a big future for the telehealth development and helping.
I think you bring up a very good point that while there may be challenges that may be hard to address in the arena of acute care cardiology, but definitely in preventive cardiology, there's a lot that we can do by interacting with our patients remotely using telehealth. I think you provide a very good segue to my next question, which is the aging of the workforce, the aging of our population in general, our patients, and the access to cardiac care, I think, is emblematic of a larger workforce problem in cardiology. How are we prepared to meet this challenge in the coming decade?
Yes. So as we all know, there's more elderly patients that we're taking care of. They're sicker than before just because they survive acute heart attacks and other acute conditions thanks to all the developments in the healthcare. But now they come back sicker and older. That leads to increased complexity of the cardiovascular care, leads to increased healthcare costs, and with the decreased reimbursements, all these are challenges. And unfortunately, I do not think that we're well prepared for that. There are different initiatives that the ACC is promoting and trying to help, but unfortunately, the gap between the need for cardiologists, which is increasing for the next 10 years at least, and the workforce that is actually decreasing over the next 10 years, there is an increasing gap. So there are certain things that the ACC can do for the workforce. One of it is to pursue changes in the training and the certification pathways. Is just taking probably too long of a time to train a cardiologist. You need the internal medicine 3 years, you need the general cardiology 3 years, and then if you have subspecialization, another 1 or 2 years. Another one is to promote and incentivize careers in general cardiologists. We really need to reach out to this population in rural Iowa, which they mostly need general cardiology. More specialized services could be done at the larger towns and cities, but we don't have enough general cardiologists, and most of the cardiologists actually go to subspecializations. So we need to incentivize them to stay in general cardiology. And that is also driving the payment reform, as I mentioned before, which will incentivize practices to keep their rural locations.
Yeah, I think I fully agree. The practice of cardiology itself is becoming very complex. Our therapeutics, our diagnostics, and for a cardiologist to know and provide such complex care on an individual level is very difficult. The training pathways are also very tedious, and sometimes can be a barrier to encouraging more and more young individuals, doctors, to pursue cardiology. What are the evolving models of care that you see that can enhance and help us do more with less? be that in telehealth, artificial intelligence, or the use of physician extenders?
Correct. Yeah, so I just briefly mentioned before about the telehealth, but yeah, that has a very strong potential, at least for initial diagnostics and for follow-up on patients. There are almost every physician office now has done at least some telehealth. And on advocacy level, again, we're trying to preserve the access to the telehealth, which actually expired with the end of the pandemic officially. But there's still some bills that are in the Senate and in the House that can extend these services. There are other models like mobile diagnostic units for echocardiography or for vascular ultrasounds, which also could be utilized so we can reach to rural areas of Iowa where the patients have trouble with mobility and reaching to larger cities. And then if these patients need like a more specialized care, specialists, or higher level services, then transportation, which is on the part of the bigger systems, arranging for that transportation and reaching to these patients and getting them into the bigger hospital and then back home is also very important. On the team approach, ACC fully embraces, and most of the cardiology practices fully embrace the team approach. That means it's not just physicians, but also nurse practitioners, different types of APPs, MAs, and nurses. We really use this collaborative and approach. I don't think there is any concern, at least in the cardiology community, much about the scope of practice, that there is a creeping scope of practice as far as nurse practitioners overtaking cardiology. I don't think that's the case. Actually, they're very helpful. We use them at the top of their license, just because the cardiologists usually are very heavily specialized, and they're the only ones that can do procedures. The APPs and nurses cannot. So we need to use these other providers to see the patients, at least initially, or for follow-ups. So we were one of the few specialties that actually fully embrace the collaborative approach with all the team members.
Fantastic. Also, there's the issue of physician burnout. We work long hours. Our patients have complicated medical issues, and caring for them is not easy. And there's a large proportion of cardiologists that are 55 years of age and older. How can we leverage cardiologists who are approaching retirement to stay within the workforce, as they have a wealth of knowledge and experience and can guide a lot of us who are early career and are just starting out in this field?
Yes, that's a very good point. And actually, what we've noticed is that actually the older cardiologists, most of them actually tend to stay. We do have in our practice a few cardiologists that are well in their 70s. What we're afraid, though, that we're losing some of the people that are in their 60s. People are actually retiring earlier just because of the burnout. It seems this middle group between 30 and 60 is the one that has the highest level of burnout. But what we can do to retain these people is it's a very complex problem, and it's not just for the healthcare, but specifically for the healthcare problem. And it has a lot to do with all the administrative tasks that we do, all the repetitive and tasks that we do not see much meaning, but just take your time, take your energy and focus. So that means a lot of reforms in the EMR space, having really efficient EMR, using AI. That's the future, and I think that will help a lot in that arena to decrease unnecessary tasks. And then again, using fully the whole team approach, so they can do tasks that could be done by them and not to burden the physician. And then also different models of employing the physicians which are near their retirement, either keeping them on a part-time or decreased call schedule. And sometimes that might cause some increased tensions in the practice, but usually if there is a good, honest talk in between the physicians in the group, and they understand that if they work less, they might get paid less, but still be part of the team and still have satisfaction with what they're doing, that could be actually quite achievable.
Thank you. The ACC has done tremendous work in not only highlighting the issues that face cardiologists at regional as well as national levels, and providing cardiologists like you and I a forum to voice our opinions and concerns. What advice would you give to young cardiologists who are in their early career phase with regard to engaging with the ACC and helping improve not only their work environment, but also the lives of their patients?
Yes, especially for a young cardiologist, and some of them, even as fellows, they might have been a part of fellow in training part of the ACC. They should stay connected with the ACC. It can give them a lot. We're talking about early career advices where they're just new into practice. There's so many new things for them, like the business of cardiology, like negotiating contracts, working with colleagues, with older and younger colleagues. So there's so many things. Iowa chapter itself, we also have early career subchapter. We have different committees. So if they want to stay engaged, they can absolutely email either me or Leslie, or just to reach out in any way to our team. We can get them involved. We can get them on different committees. And then in general, just to follow our newsletter. It usually goes to every member of the ACC. The Iowa chapter sends newsletters, which are every few months. There are different opportunities in these newsletters where they can get engaged with the ACC. We put really burning topics and news that might be of interest. And then also just to, in general, not just for the early career, but any practicing cardiology in Iowa, I would recommend that they stay active and just be advocates for their patients and help with the advocacy efforts of the whole ACC. At times, there are different bills that are to be introduced either at the state level or the national level, and we need the support of all the cardiologists to either for or against. Usually in these newsletters, we send it as a red alert, and there is the click of the button that you can open the actual letter that gets sent to your own representatives, and then you just sign it. You can also add something additional, but that really helps with our efforts to pass reforms that are actually beneficial for cardiologists and patients.
Thank you. On a personal level, I will add that I have learned a lot through my association with the ACC. Issues pertaining to the actual practice of cardiology, as we call the real world. These are things that are not easy to understand as fellows as we go through the rigors of our training. And I think in that respect, the ACC has been tremendous in giving us the ability to interact and network and learn from other cardiologists as well. Well, thank you so much for your time, Dr. Kotev. This has been a very informational and instructive talk. I thank you again for giving us this opportunity. And thank you all for tuning in to the Iowa ACC podcast. We hope to have further discussions with other cardiologists on cardiovascular issues affecting our practices. Thank you.
Thank you very much, Amit. It was a pleasure.